Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be talking on one of the topic which is very frequently asked as a short note in your theory. Also, once in a while you will see such patient in your everyday practice. So if you are aware of it, you can pick up those cases and you can investigate and treat them. That is Raynaud's phenomena, or we call Raynaud's syndrome. So there are two common terms which are being utilized, Raynaud's syndrome and Raynaud's phenomena. Also, there is one word called Raynaud's disease. Raynaud's phenomena will include pallor, followed by cyanosis, and then redness. Will be commonly, as usual, we'll be discussing under these headings. That is definition. Now, there are three common words which are being utilized: Raynaud's disease, syndrome, or phenomena. So, when we use the word Raynaud's disease or Raynaud's syndrome, phenomena will be a finding, while disease and syndrome will be a group of symptoms and signs. In syndrome, there will be many etiology which can have a similar group of syndromes, symptoms and signs. While Raynaud's disease, it is a specific condition where you will have a Raynaud's phenomena. Basically, Raynaud's is a rare disorder that will affect the arteries. There is a vasospasm of a artery, and because of vasospasm, there is a reduced blood flow to the finger and toes, the distalmost part of our body, and may also affect tip of the ears and tip of the nose. Primary, where we don't know the etiology, it is also called as a idiopathic or primary. We can call that as a primary Raynaud's or Raynaud's disease, where we don't know exact etiology. While in secondary, we call secondary Raynaud's or Raynaud's phenomena, where the causes are known and there are multiple different causes which may lead to Raynaud's phenomena. So indirectly, Raynaud's disease is always primary, while in secondary there are multiple different conditions which can produce Raynaud's phenomena. We'll be going through that one by one. And together we can call primary Raynaud's syndrome or secondary Raynaud's syndrome. So usually terminology which are being utilized, we call primary or idiopathic Raynaud's, where one of the term utilized, one of the most common cause of primary idiopathic Raynaud's, we call Raynaud's disease. We also call that as primary Raynaud's syndrome or idiopathic Raynaud's phenomena. But here we don't know the exact etiology. It is very common in female. All those will be having a one slide where we'll be explaining in short. While secondary Raynaud's, we also call secondary Raynaud's syndrome, but we don't call that as a secondary Raynaud's disease. So Raynaud's disease is only in case of primary, while in secondary we call Raynaud's phenomena or we call secondary Raynaud's syndrome. These are the two common different types. We call primary or secondary. There is one more group we call undefined, where there is no specific symptoms and there is non-definite laboratory abnormalities. So basically we have got 90% of the people will have a Raynaud's disease, or we call primary Raynaud's, and 10% will be having Raynaud's phenomena or secondary Raynaud's. Primary Raynaud's is isolated condition with no connection to the medical problem. It is most commonly affecting the woman before the age of 40, and disease is for more than 2 years and has not developed any additional manifestation and are at low risk for developing autoimmune disease. This is one big group, and it is accounting for almost 90% of the cases who presents with Raynaud's phenomena. While 10% of the people, they starts later in life. It is connected to good number of medical conditions and underlying disease, and that can be also secondary due to lot of different etiology like vibrating tools or jackhammer disease, etc. What is Raynaud's phenomena? Raynaud's phenomena is an episode which happens in digit, that is finger and toes, distal most part of finger and toes, where secondary due to arterial vasospasm, you get ischemia, in which you see pallor, cyanosis followed by redness. It is precipitated by exposure to cold or occasionally by emotional stress. In 10% of the people, person will have a sclerodactyly. It is more common in female as compared to male, and the age is between 20 to 40. Good number of times these people are having associated migraine or variant angina, which are also vasospastic disorders. So basically it is a vasospastic disorder where because of the spasm of the artery, there is a discoloration because of ischemia. Initially you develop pallor followed by cyanosis, and when spasm is relieved, there will be appearance of redness. So Raynaud's phenomena will occur in Raynaud's disease, which we also call as a primary Raynaud's, or we also call as a idiopathic. While Raynaud's syndrome is secondary Raynaud's, where you know the cause, you know the triggering factor, and the most common cause of Raynaud's syndrome is connective tissue disorder. In Raynaud's phenomena, because of initial spasm, there is ischemia, you will have appearance of pallor, followed by, as oxygen is being utilized, you get cyanosis, and then vasospasm gets relieved, blood circulation recurs, this will be red. This can, most commonly what is being affected is tip of the finger and tip of the toes. Occasionally you can get involvement of the ear lobules or tip of the nose. So pallor, that is blanching, followed by cyanosis, that is bluish discoloration, followed by redness. It is after exposure to cold or because of stress, and with removing those findings disappears. You will have appearance of redness again. That's why we say that occasionally it is precipitated by emotional stress also. This is because of spasm of small arteries or arterioles. Pallor, cyanosis, followed by redness. That there is one another word called as acrocyanosis, which is persistent, painless, symmetrical cyanosis of hand, feet and face caused by vasospasm of small vessels on exposure to cold. The digits, hands, feet are persistently cold and bluish. There is sweating and there may be appearance of edema. Unlike Raynaud's syndrome, cyanosis persists and it is not easily reversed. Trophic changes and ulcer do not occur. Pain is absent, but the pulse are normal. This very frequently will be seen, very common in a newborn children's. We call acrocyanosis. That is on exposure to cold. There is spasm of the arteries, small vessels leading to these findings. That is painless symmetrical cyanosis affecting the distal most part, or we call exposed part of the body. Etiology we have already divided into primary and secondary. In primary, we always call idiopathic. It is very common in female as compared to male. Smoking worsen the frequency and intensity of the attack, so it is one of the factor. They say that there is also hormonal factor. Caffeine can also worsen the attack, and very frequently it is also associated with migraine or vasospastic angina. It is precipitated by exposure to cold, emotional stress, and any condition which produces blood vessel spasm. While secondary is most commonly because of collagen disorders like scleroderma, Crest syndrome, SLE, RA, dermatomyositis, polymyositis, Sjogren's syndrome. This is not diabetes mellitus. You can have arterial occlusive disease like thromboangiitis obliterans, thoracic outlet syndrome. In some cases of pulmonary hypertension, also in neurological disorders like intervertebral disc disease, syringomyelia, spinal cord disorders like tumors, stroke, polymyositis, compressive syndromes, that is carpal tunnel syndrome. As far as blood is concerned, elevated level of cold agglutinins, cryoglobulins, cryofibrinogenemia, myeloproliferative disorders, macroglobulinemia. In traumatic injury, we call vibration injury, hammer hand syndromes, electric shock, cold injury, when person is extremely exposed to extreme cold, typing, drugs like ergot derivatives, methysergide, beta blockers, bleomycin, vinblastine, cisplatin, etc. In secondary Raynaud's, there are some risk factors like age. It will usually start in 4th decade. Person who are working on piano or typing, injury to hand and legs, repetitive actions, the person who are constantly exposed to extreme cold, smoking, certain medications. These are all other. It is 50% of the patient with Raynaud's phenomena where ratio is almost 1:5, age 20 to 40. Fingers are more affected than toes. One or two fingertips or entire finger may be affected. Rarely earlobes, tip of the nose, very rarely glands. 7 to 90% are female. It is affecting 3 to 5% of population. Women's to, that is male to female ratio is almost 1:5. Age we already mentioned between 20 to 40 years. and symptoms will increase between menarche and menopause, suggesting there is some hormonal factor which is playing a role. Secondary Raynaud's, it is very common in, we call systemic sclerosis. 80 to 90% have got Raynaud's phenomena. Ischemic fingertips will show you ulcer, gangrene and auto amputation. In SLE, it is almost 20% will have a Raynaud's phenomena. Dermatomyositis and polymyositis, almost 30% of the patient will have Raynaud's phenomena. RA also has got frequently Raynaud's phenomena. Arteriosclerosis of extremities in male is more than after, it is much more after the age of 50. Burger's disease is uncommon. It is very common in younger individual and person who are smoking. Medium size to large size artery occlusion due to thrombus can also end up with Raynaud's. Thoracic outlet syndrome can occasionally have Raynaud's phenomena. Pulmonary hypertension can also have, and blood dyscrasia like hyperviscosity and abnormal proteins like gamma globulins, etc. If we go through a pathophysiology, either because of stress or because of exposure to extreme cold, the most common precipitating factor or stimulating factor is this. They stimulate sympathetic stimulation, and that will stimulate vasoconstriction. And once there is a vasoconstriction, person will start developing hypoxia in that particular part, which will produce pallor. Because of anaerobic metabolism, lactic acid production, person will start getting pain. Now, because of utilization of oxygen, now there is severe hypoxia which will result into cyanosis. So, on exposure to cold, there is a triggering factor. Small arteries of the finger toes going into vasospasm, less blood flow, low oxygen supply. Now, this will produce anaerobic metabolism, lactic acid production. So, there will be pallor with pain. Now, if you warm up, artery will dilate, and once artery dilate, blood flow increases, oxygen supply increases, color will change back to bright red. And now affected area is warm, and there may be throbbing pain for some period of time. Then that pain also disappears. Now, if this spasm persists, oxygen is utilized, person will develop cyanosis. And now either spontaneously there is a vasodilatation, or by warming, or by drugs, this phenomena will take place. So you will have appearance of pallor, cyanosis, and when there is a warming, artery dilates, or there is a spontaneous dilatation, it will give rise to redness. By and large, warming helps a lot, or drugs may help you. So this will be typical phenomena. Now, if this spasm persists for a longer period, because of hypoxic damage, now you will have appearance of an ulcer formation. It is more common in secondary phenomena or secondary Raynaud's, where you will start getting small digital ulcers which will deepen out. You might develop necrosis, which will end up with what we call as gangrene, and there will be auto amputation. This is very common in collagen disorders like systemic sclerosis, or we call scleroderma, and it is also common in other collagen disorders, but the frequency is less, like SLE, rheumatoid arthritis, Sjogren's syndrome, etc. So cyanosis will appear due to deoxygenated blood, rewarming, blood flow improves, hyperemia, and person will have a warm tip with throbbing pain. That is because of vasodilatation. So exposure to cold or stress or caffeine or by drugs, sympathetic stimulation, vasospasm, and skin color changes. And these are all the different factors which are also responsible. Like cold and stress, most common, caffeine can precipitate, certain drugs can precipitate, most notorious. Also, there is one factor we call as a genetic factor, autoimmune disorders, hormones, vibrating instruments, and increased sensitivity of arteries. So there will be intermittent spasm which will produce skin color changes and pain. That will be very, very typical. Usually it will affect the fingertips. This is fingertips, toes, and it may affect the peripheral tissue. So stress will stimulate sympathetic system, release norepinephrine, which will produce vasoconstriction. Also, digital ischemia. In Raynaud's phenomena, there will be certain things which will be happening in a secondary etiology. That is, say we take an example of scleroderma. There is an intimal proliferation. There is a fibrosis, narrowing of the arterioles, and secondary to this, now there is ischemia, hypoxia, infection that will further aggravate endothelial insult, platelet activation of lymphocytes, which will activate or decrease the level of prostacyclin and nitric oxide. Thromboxane and serotonin level will be increased, which will produce vasoconstriction, and that will lead to what we call as classical Raynaud's phenomena. And this is for a long period. You will get gangrene, and then you will have auto amputation. Good number of times the person is asymptomatic, and when the person is asymptomatic, if we can demonstrate vasospasm on exposure to extreme cold, that stage we call as a latent. But if person already presents with the symptoms on exposure to extreme cold, we call manifest variety. It will affect most commonly fingertips. Person will have a pain, pallor followed by cyanosis, and then there will be redness. Due to persistence of spasm, you can have ulceration, gangrene, and auto amputation. You can have involvement of ear lobules, nose tips, very rarely tongue, even lips may be affected. So we have already told you that attack will consist of pallor followed by cyanosis and followed by erythema. In primary Raynaud's, it is symmetrical and it involves multiple digits. In secondary Raynaud's, may affect one or two fingers or few digits, and very frequently it is asymmetrical. Attacks are usually precipitated by cold or anxiety, stress, etc. May be also precipitated by sometimes drugs. We have already told you that during attack, pallor, cyanosis, pallor is followed by cyanosis, then you will have a tingling numbness, the tips will be cold, and there will be pain. When it turns red, there is a throbbing, pain, tingle, or burning sensation may still be there, and later on it disappears. So pallor, cyanosis, and then followed by rubor. So you have got pallor, cyanotic phase, and hyperemic phase. It can affect tips of finger, toes, thumb, rarely nipple, nose, ear lobules. We have told you two common: exposure to cold and emotional stress. And during that, the person will complain of pain, tingling, numbness, etc. And if it persists for longer period, you can have necrosis, gangrene, and auto amputation. These are all the triggering factor: cold exposure, stimulation by emotional stress, etc. And these are the area which can be affected: toes, ear lobules, face, knee, nipples, all those things can be there. So now if you want to approach to any person who comes to you with a Raynaud's phenomena, first is a good history. The first question is what happens. So if a person says that on exposure to cold, I get so and so phenomena. Now you observe that particular phenomena, you will have a pallor followed by cyanosis. And then depending upon the different findings, you will have to calculate the score. You will have to calculate the disease score utilizing all these different criteria. So this is what you can see here. There is a gangrene, what has appeared, dry gangrene we call, and this is auto amputation has occurred. So this will be a very common phenomena which will happen very frequently in a secondary variety, and particularly we call systemic sclerosis, quite common. Now for diagnostic purpose of Raynaud's phenomena, repetitive episodes of biphasic color changes on exposure to cold will call definite Raynaud's phenomena. If there is a uniphasic color changes plus numbness or paresthesia on exposure to cold, possible. And if there is no color changes on exposure to cold, no Raynaud's phenomena. This is simple clinical clue. Criteria for primary or we call Raynaud's disease, it is always symmetrical. It is precipitated by on exposure to cold or emotional stress. Usually there is no necrosis and no gangrene. There is no clinical history or physical findings suggestive of a secondary etiology for Raynaud's phenomena. There is a normal ESR and serological finding ANA will be negative. And if you look at the nail fold capillaroscopy, it will be normal. While in case of a secondary on capillaroscopy, you will get dilated arterioles and there will be dropouts. So this is a difference which we have already told you in a systemic sclerosis. We'll divide into two groups, primary Raynaud's and secondary Raynaud's. In primary Raynaud's, 90% of all cases are there with Raynaud's phenomena. While in secondary, it will be more than 10%, but less common. Age in primary Raynaud's is between 20 to 40, while secondary Raynaud's is usually later in the life. Here you can't identify the exact etiology. It is very, very common in female as compared to males. While this, there is a definite etiology like systemic sclerosis, SLE, rheumatoid arthritis, Raynaud'S syndromes, thoracic outlet, carpal tunnel, traumatic injury, vibration. We have shown you all the causes. Here it is bilateral symmetrical, affecting upper limb as well as lower limb, quite common. Multiple fingers are being involved. While here, usually it is affecting one or two finger asymmetrical, very common. Person is normal in between the two episodes, while in this particular person might have persistent phenomena for a longer period because of involvement of the arterioles, endothelial proliferation and occlusion of the vessels. There is a very strong family history in case of a primary Raynaud's, very strong family history. Here also there is some genetic factor which are playing role in systemic sclerosis, RA, SLE, etc. Here it is symptomatic treatment and then you can go for sympathectomy. Well, in this particular condition, you will have to treat the basic underlying cause, basic etiology. This is again a difference. We already told you that in secondary, the most common cause is systemic sclerosis, Buerger's disease, RA, SLE, etc. Onset here is less than 20 years, close to 20 in primary, while this is in a late age. Familial, strong family history. This may be familiar or may not be familiar. There is a vasospasm on exposure to extreme cold. Here also you will have, but it will be asymmetrical. This is good number of time asymmetrical. In this, the pulse will be normal, while here pulse may be diminished or absent because of involvement of the arteries also. Usually there is no significant ischemic changes and there is no necrosis or no gangrene, while invariably here there is a fingertip ulceration, gangrene, etc. and auto amputation. There are no other findings in case of primary Raynaud's like involvement of skin, joints and systemic involvement, while it is most common in case of secondary. ANA, RA factors are usually negative, ESR is normal, while ANA is strongly positive, RA factor may be positive, ESR may be elevated, CRP will be elevated. We already mentioned that nail fold capillary scopy will be normal, while here invariably you will get an dilated capillaries and dropouts. Typical, now there are a lot of photographs. See, you can see this is typical pallor. Here only two fingers is affected, here only one finger with little amount of palm involvement, and these are normal. Here you can see that all these fingertips are showing cyanosis. This will be more commonly primary. This will be more common in case of secondary. This will be, you can see a ulceration. You can see tip ulcers, fingertip ulcer. This has to be secondary etiology. All fingers are involved, secondary. Pallor in almost all. Sorry, this will be primary. This will be primary. This will be again more common in primary. Well, this will be secondary. This too will be secondary. Yes, very rarely you get involvement of the Raynaud's phenomena at nipple level. I'm skipping this slide. At your leisure time you can go through. Very rarely you can come across Raynaud's involving lungs. Very uncommon. There is one word which is very frequently utilized is juvenile Raynaud's syndrome. There is also one another word, oral contraceptive with Raynaud's phenomena, very common in female and also in a female who are on hormone replacement therapy. You can also have vibration syndrome very frequently because of vibration injury. There is damage to nerves which can produce Raynaud's phenomena. Ergots and beta blocker can produce Raynaud's phenomena because of vasospasm. In Craig syndrome also there is one of the component of Craig syndrome is Raynaud's phenomena, which is usually associated with calcinosis, esophageal dysfunction, sclerodactyly and telangiectasia. You can see telangiectasia, this. quite common. This is calcinosis, Raynaud's phenomena, esophageal motility disorders, sclerodactyly, and telangiectasia. Primary Raynaud's phenomena, we already told you there will be intermittent attacks of discoloration, usually precipitated by one exposure to cold. There is no clinical evidence of peripheral artery occlusion. It is by and large bilateral symmetrical. There is no occupational disease, traumatic injury, drugs, etc., which gives rise to vasospasm. ANA is negative, RA test is negative, very common in female and very common in early age group. Normal nail fold capillary, normal ESR, and symptoms will be for a longer period, say at least for 2 years. This is how you approach to the Raynaud's phenomena, little bit in detail. If you are interested, you can go through. This slide will help you how you differentiate Raynaud's disease, scleroderma, lupus, RA, or we call collagen group of disorders, and occlusive disorders like embolism, vasculitis, atherosclerosis, thromboangiitis obliterans, thoracic outlet syndrome, etc. So this will be how you approach. At your leisure time, you can go through. This is again another slide showing you how you approach to the person with Raynaud's phenomena. It is little bit in more detail. If you are interested, you can go through at your leisure time. This is again another slide showing you how exactly these are all different algorithms which you can utilize for approach to a Raynaud's phenomena. Most important is history and physical examinations. A simple most test for Raynaud's phenomena is ask the person to dip the hand in ice cold water for 5 minutes. A person who has got a positive Raynaud's phenomena will have fingertips becoming blue, cyanosed, and person will start complaining of tingling, numbness, and pain. And when you ask to dip in a warm water, spasm is relieved, cyanosis will disappear, person will have a redness. For short period, person will complain of throbbing pain, little tingling, numbness, and then it will disappear. As far as primary etiology is concerned, there is no laboratory test or no other phenomena. But to exclude secondary, RA test is negative, AN is negative, and even C reactive protein, ESR, etc. will be normal. And if you do nail bed capillary scopy, it will show you normal capillaries. While in case of secondary, you might require certain investigations, mainly to rule out collagen group of disorders. The commonest test we call as a cold stimulation test, nail fold capillaroscopy, ANA, ESR, and CRP. ANA can be associated with RA factor also. This is nail fold capillary. This is normal. You can see these are little dilated capillaries. You can see this, and there is a dropout. This will typically be in case of a we call scleroderma, etc. secondary groups. This will be typically seen in a secondary group. You can see this is dilated capillaries, and here there is a dropout. These are dilated capillaries. These are dropout, dilated capillary with dropouts. You can have this clearly. You can see a little dilated capillary. Usually in secondary, you might require renal function test, PT-INR, creatinine, serum glucose, thyroid function test. All those may be necessary. There are some tests which are being advanced tests, we call thermal gradient test, to find out the amount and severity of arterioles involvement. These are the different varieties of tests which can be done. Thermal gradient finger test can be done. This is laser speckle contrast imaging to find out the amount of arterial involvement. There is a focal Raynaud phenomena which you can demonstrate by different tests, particularly iPad. You can utilize that. Differential diagnosis, you will have to differentiate from other condition which produces Raynaud's phenomena like carpal tunnel syndromes, thoracic outlet syndrome. Also you can have in TAO, vasculitis, etc. These are all necessary in secondary groups. So you will have to differentiate primary from secondary. Also you will have to differentiate cold injury like frostbite, chilly bends, etc. As far as management is concerned in primary, usually all is symptomatic and prevention, while in secondary, treat the basic etiology. There are certain things which will help: stop smoking, regular exercise, control stress, avoid caffeine, and take care of feet and hands, and warm clothes. So wearing a warm clothes helps a lot. Loose fitting clothes will be helpful. Avoid prolonged vibration injury to the finger. Stop smoking. Topical treatment is more helpful. Drugs to some extent may be helpful, particularly vasodilators like nifedipine. Surgery is helpful in some group of people who has got persistent symptoms, that is sympathectomy, which can be surgical or chemical sympathectomy. So we have already mentioned all this: avoid smoking, avoid exposure to cold, warm clothings, etc. Drugs like beta blocker should be avoided, caffeine should be avoided, amphetamine, cocaine, all this should be avoided. This should be all avoided. They have tried low level laser therapy, is helpful. These are all precaution you should take. We already mentioned before. No smoking, wear warm clothes, no tight clothings, avoid medication which produce vasoconstriction, control stress, exercise regularly, take care of feet and fingertips, all those things. There are some, they try acupuncture, electrotherapy, massage, chiropractic, hydrotherapy, aromatherapy, etc. are being tried, but they are not 100%. These are all the drugs which can be helpful in case of a Raynaud's phenomena. The most common utilized is calcium channel blocker. Usually these are not so helpful. You can utilize alpha blocker, nitrates, inhibit PDE4 inhibitors like pentoxifylline, etc. are helpful. These PDE5 inhibitors are more helpful in pulmonary hypertension. These are all the drugs which are there. Complications, most common complications is gangrene, ulcer. These are more common in secondary Raynaud's, and secondary to ischemic damage. You can have deformities of toes, finger, etc. And there are auto amputations. So I thank you all for taking out time. I know that your time is valuable, and I appreciate you for spending some of the time with me. So I end my lecture here. I hope this lecture will be helpful to you. Recently only we have seen one case of Raynaud's phenomena. That's why I put this in little detail. You might see once in a while in your practice. And when you see, and if you can differentiate primary from secondary, you will be able to give the additional treatment for those particular group of people. So I end my lecture here. See you next time.